Good afternoon, folks. This afternoon's topic A is why universal health coverage doesn't exist in the US. A deeper dive into the physician's perspective. Okay, I'm going to go through that for you for A. Please join me in today's discussion A. Here we go. This review article offers a sobering yet pragmatic analysis of why the United States, despite its wealth, medical innovation, and global influence, has failed to implement universal health coverage written from a physician's vantage point. It blends historical insight, policy critique, and reform proposals to illuminate the structural and political barriers that keep UHC out of reach while offering two feasible pathways forward. The structural puzzle of U.S. healthcare. The U.S. healthcare system is not the product of deliberate design, but of historical layering. Over the past century, it evolved into a fragmented mosaic of employer sponsored private insurance, dominant since World War II, public programs like Medicare for seniors, Medicaid for low income families. Low income individuals. CHIP for children, Veterans Affairs, and Indian Health Services or service. A vast for-profit sector encompassing insurers, hospitals, pharmaceutical companies, and private equity backed providers. This complexity creates entrenched interests. Insurers, pharmaceutical firms, hospital systems, and even state governments that resist sweeping reform. This result is a system where coverage is uneven, costs are high, and millions remain uninsured or underinsured. The cost conundrum. Proposals like Medicare for all often falter politically due to fears of massive tax hikes and disruption. The author argues that while the U.S. already spends more per capita on healthcare than any other country relocating existing funds and targeting insufficiencies could finance UHC without collapsing the system of targeting of triggering economic shock. Historical roots of fragmentation. The article traces the evolution of American healthcare. 19th century local nonprofit hospitals and private practice dominated. Early 20th century prepaid plans like Blue Cross Blue Shield emerged. Mid-century public programs were added, but without integrating existing private systems. Late 20th century onward, rising costs, employer-linked coverage, and privatization deepened fragmentation. This historical layering created a system resistant to simplification. Unlike countries that built national health systems from the ground up, the US must retrofit reform into a sprawling multi-tiered infrastructure. Two pragmatic pathways to UHC. Rather than advocating for full-scale nationalization, the physician proposes to incremental models. Medicare expansion for the uninsured, goal: cover 27 million uninsured Americans by expanding federal Medicare. Why not Medicaid? Medicaid's state-federal structure allows states to opt out, leading to coverage gaps. Estimated costs: $7,000 per person annually, funded through modest tax increases, negotiated drug prices, and care management savings. Advantages: builds on existing infrastructure, avoids disruption to employer-sponsored plans, and offers a uniform federal solution. Mandatory two-tier system. Baseline, universal public Medicare option for all. Private tier, optional upgrades for those who want extra amenities, e.g. private rooms, provider choice. Safeguards, ACA protections. Remain private premiums capped providers paid more by private plans face higher taxes to discourage preferential treatment. Employer role. Employers continue contributing, but private plans must meet public standards. This model mirrors systems in countries like Germany and the Netherlands, where public coverage is universal, but private options coexist under strict regulation. Financing without shock therapy. The article emphasizes that UHC can be funded through small federal tax increases. Relocation of household discretionary spending, savings from negotiated drug prices, efficiency gains in Medicare case management, workforce retention programs to reduce per enrollee costs, rather than relying on sweeping tax hikes. The author advocates for targeted politically palatable reforms that tap into existing inefficiencies and underused resources. Political realism and reform strategy. Both pathways are framed as politically feasible, but they preserve employer sponsored insurance for those who want it, avoid immediate displacement of private insurers, build on existing federal programs, offer choice and flexibility while ensuring universal baseline coverage. This incremental approach is designed to sidestep the political landmines that have derailed past reform efforts. Conclusion: reform without revolution. The physician concludes that abstinence of UHC in the US is not due to lack of solutions, but to institutional interior and fear of cost. By proposing two realistic finance incentives, finance incentives models, Medicare expansion, and a regulated two-tier system. This article offers a roadmap for achieving UHC without dismantling the current system or triggering economic upheaval. It's a call for bold, pragmatism, reform that respects the complexity of the American healthcare landscape while moving decisively toward equity, access, and sustainability. Okay, guys, that's your A for today. I'll be back on shortly with B. Give me a bit for B, please. And I'll be back on with that for you. For now, Gator Wellness, take care, folks.